talk about congestive heart failure. Congestive slash heart failure. So let's break down the pathophysiology of CHF. CHF is your heart. Your heart is a pump, right? It's just a pump. It takes blood from point A to point B and making sure that that it's oxygenated and removes CO2, right? That's all the heart does. It pumps and out, pumps and out. So when you look at that force that the heart needs, right, what's called the ejection fraction, anywhere between 60 to 65%, that's what the normal heart function does to squeeze, right? In congestive heart failure, that function has now been decreased. They had a STEMI, they had a non-ST segment elevation, they had a infectious disease of the heart. Anything that affects the heart, that affects that function, cause heart failure. So if you go down to 50%, then you have first stage of heart failure as all the way to severe as 10 to 15. Now I want everybody to understand the heart is not just to send the blood flow, but that's what gives us the energy to do anything. For me to stand up right now and to be able to speak in a minute without taking a break, I need to have a normal heart function. Somebody who has limited heart function has limited activity, right? So imagine those patients. They have decreased pump, the blood is going to get backed up. Remember we talked about the right side of the heart as a volume, right? So now the blood's going to come back to the right side of the heart. It doesn't have enough force to be pushed, so it's going to go into the lungs and it's going to back up into your lung. And once it backs up into the lung, that's caused pulmonary edema, right? And so congestive heart failure with pulmonary edema, now you understand the physiology. Now we put the symptomology, meaning the symptoms, right? Shortness of breath, right? They're tripoding, right? They're tripoding. They have hypertension early, right? Because their system is trying to compensate, right? For the lack of oxygen or lack of function of the heart. They're gonna have pulmonary edema, rails everywhere, right? So this is the physiology that we need to understand. And we're gonna give oxygen, but oxygen is just one treatment. What's the major important part of treating this patient? Their vascular system, their vein, right? Most of our blood supply is kept on the venous side, right? We have arteries and vein, right? So the venous side is what's called the accommodating system. Most of our blood supply is always into our vein, and about 2/3 of our blood supply is going to be in the vein. Very small amount of blood is in the artery, right? The artery is a thick, so it doesn't accommodate for much blood. In congestive heart failure, we want to cause vasodilation. Think of your tank, right? This is my tank, my blood tank. My blood tank is 6 liters, right? If I cause vasoconstriction, right? That means I'm going to take my tank and I'm going to squeeze my tank, right? I'm going to take my 6 liters and make it 3 liters, right? That means I'm functioning on 3 liters. That means a whole lot of blood, right? And then that's going to worsen the pulmonary edema, worsen the congestive heart failure. So what do we want to do? We want to vasodilate. We want to affect the venous part of the blood system and make it wider and wider. So we take that 6-liter tank and we're going to make it 8, 9, 10 liters. All the blood now is pulled to the extremities or pulled to different part, away from the heart, away from the lung. That's how we're going to treat. What medication do we have? Well, this is why we give nitro sublingual. You're giving 0.4 milligram of nitro. That's 400 microgram of nitro. Nitroglycerin is a venodilator, right? It's gonna do exactly this, affect the venous to dilate, to make the tank bigger. We're giving it sublingual. The problem with sublingual nitro is we talked about absorption, we talk about blood flow, and one of the problems sublingually is the pill may not get absorbed into the because of vasoconstriction, right? It's so tight, so the blood supply into the face may not be as delivering into the system. And so if it doesn't work, the blood pressure is systolic 160 or greater, you've given 0.8, meaning 2.4 milligram. Then we're going to go to our new protocol where now we're going to give it intravenously. And understanding intravenous, you're going to take 600 microgram of nitroglycerin. You're going to put it in a 50 milliliter bag of normal saline, and you're going to run it wide open, right? And you're going to deliver 600 microgram into the venous system. This is going to go everywhere into the system. It's going to affect the entire system much faster. Something to watch. Look for the systolic blood pressure. As you're running your nitro, if suddenly the blood pressure drops all the way down to like 80, 90, close it and take a deep breath. Okay, nitro is a very short-lived medication. All right, 1, 2, 3 minutes, the medication will be gone and the patient blood pressure will start. Don't start panicking. Don't start like, oh, now I got to chase it and give a fluid. You're only going to give fluid to those patients if they're not responding after 5 to 8 minutes when you hold nitroglycerin. Simultaneously, we're going to do CPAP, right? CPAP, again, is continuous positive pressure, right? It's what CPAP is PEEP, right? In a vent, PEEP. In a non-ventilated patient, CPAP. Same terminology, same mechanism. So what you're doing is now you're creating the negative pressure. You're going to open the alveoli to allow for more gas exchange. Not only are you going to allow for more gas exchange, but that pressure into your chest is going to allow for blood, again, to vasodilate, right? And then what we want the blood to be shifted and make the container wider, right? In contrast, right, I'm going to give you a contrast, right? In patients who are trauma, bleeding, right? They're bleeding. What's happening? The 6-liter tank is getting shorter, right? And then there's not enough force to go to the heart. That's complete the opposite, right? That's why we're going to give fluid. In CHF, the tank, we want to make the tank bigger. So CPAP will increase that tank. Vasodilation medication will increase that tank. Maintain oxygenation anywhere between 88 to 90%. Again, do not try to normalize a number that probably will never be normal. You can't fix a bad heart with what we have in our protocol. Most of those patients are secondary to a disease process, either dietary indiscretion. They're supposed to be on 2-gram salt diet. They went out with their family and they took too much salt. Or they have new worsening heart disease, a new MI, a new non-ST segment elevation, the importance of our EKG. Check for a new onset of infection, looking for sepsis surge criteria. And treat the patient, and thank you.